Thank you. It is 45 after the hour, and we will reconvene our meeting. We'll move on to the next session for the morning/afternoon on pneumococcal vaccines. Dr. Kathy Paling, chair of the pneumococcal work group, will provide an introduction and the context for today's discussion. Dr. Paling, the floor is yours.
I want to welcome you to the pneumococcal vaccines work group. Next slide, please. All right. And so I want to spend a moment and say a special thank you to all the ACIP members, the ex officio members, the liaison and representative and consultants who have really spent a lot of time discussing these issues, and to the stellar leadership from Dr. Mowako Kobayashi. Next slide, please. In addition, we need to mention that this presentation would not be possible without the tremendous contributions of many throughout the CDC and the grade and evidence to recommendation consultants. Next slide, please. All right, so to frame this conversation, first I want to talk about the current recommendations. There are two pneumococcal vaccines that are currently licensed. One is the 23-valent pneumococcal polysaccharide vaccine that we'll refer to as PCV23. The other is the 13-valent pneumococcal conjugate vaccine, PCV13. Those are considered our current recommendations. There are two recently licensed vaccines. The 20-valent pneumococcal conjugate vaccine, which we'll refer to as PCV20, was licensed for adults for use in adults 18 years of age and older on June 8, 2021. In addition, the 15-valent pneumococcal conjugate vaccine, PCV15, was licensed for use in adults 18 years of age and older on July 16, 2021. Policy options for PCV15 and PCV20 use are being evaluated separately, and each vaccine, PCV15 and PCV20, will be compared to the current recommendations. Next slide, please. So currently, this is what our pneumococcal vaccine recommendations look like. If you're 19 to 64 years of age without chronic or high-risk medical conditions, there's no vaccine recommended. If you have chronic medical conditions, PCV23 is recommended. If you have a cochlear implant or CSF leak, it's PCV13 and PCV23 in series. And then if you have an immunocompromising condition, you also get PCV23 repeated after 5 years. If you're over 65 years of age, pneumococcal PCV13 based on shared clinical decision-making, and PCV23 for all. And then if you have a cochlear implant, CSF leak, or immunocompromised conditions, it's PCV13 and PCV23 in series. Next slide, please. So one of the components that the work group is striving for is to simplify the risk and age-based recommendations. There are two age-based recommendations going, and the goal is to have a single age-based recommendation, whether it be at 50 or 65, and then the same risk-based recommendation across chronic medical conditions, cochlear implants, CSF leak, and immunocompromising conditions. Next slide, please. The target age group for the age-based recommendation will determine the ages that are eligible for the target population for the risk-based recommendation. And for that reason, for each vaccine, we're going to discuss the age-based recommendations and follow that by the risk-based recommendation. Next slide, please. So in June of 2021, we presented the cost-effectiveness analysis and public health impact, as well as the grade and evidence to recommendation for PCV15 as well as PCV20 in older adults. We appreciate the feedback that we got, and so today we're going to be incorporating that feedback in the comparison of cost-effectiveness analyses, as well as the grade and evidence to recommendation for use of PCV15 as well as PCV20 in adults with underlying conditions. This is to prepare us to be prepared to make a vote in October of 2021. Next slide. And so since the June ACIP meeting, the work group has reviewed updated cost-effectiveness analyses based on feedback, and we've added models with 50 and 65-year-old cohorts. We've updated key inputs for base case, which includes weighting of PCV, modifying the VE assumptions, as well as vaccine cost. And we performed additional one-way sensitivity for lower VE for PCV20, higher vaccine coverage for PCV-only use. We have discussed risk-based use of PCV15 and PCV20, and we reviewed the new cost-effectiveness analyses findings and revisited the policy options. Next slide, please. So, as you may recall, we considered both each vaccine with and without PCV23 at two age groups, over 50 and over 65, and then the risk base for persons 19 to that age group. So there were originally 8 policy options under consideration. Next slide, please. So when we look at the PCV options considered for cost-effectiveness analyses, I want to review where we have come down. And before I start, I want to reiterate a point that Dr. Ortega-Sanchez made earlier. Cost savings means that the intervention improves health outcomes and is a lower cost than the current recommendation. So when we looked at over 50 and the PCV only option, we found worse health outcomes than the current recommendation in most scenarios for both the CDC and the Merck model. When we looked for persons 50 and older, PCV15 and polysaccharide vaccine, we had worse health outcomes than the current for the CDC model, and we had improved health outcomes and increased cost in the Merck model. Then we looked at the 65 years and older. For PCV15, we found worse health outcomes than the current recommendation for the CDC model, and we found cost savings in the Merck model. The last consideration, 65 and older, was PCV15 and PCV23. In this model, we found cost savings in the CDC model and improved health and increased cost in the Merck model. So we focused on the one that is highlighted. Next slide, please. So for the PCV20 options under consideration, I first want to talk about the vaccine itself for 50 and 65. For PCV20 at 50, we found a variety of results from cost savings to worse health and lower cost compared to the current recommendation for the CDC model, and we found improved health and increased cost in the Merck and Pfizer model. For PCV20 at 65 years of age and older, we found a cost savings in the CDC and Pfizer model, and we found between a cost savings to improved health and increased cost in the Merck model, depending on the scenario. So to summarize, PCV20 use at 65 and older was cost saving in most models, and PCV20 use at 50 years of age and older improved health outcomes in most scenarios and was cost saving in some CDC models. Next slide, please. Okay, now we considered PCV20 in series with polysaccharide vaccine. For 50 and older, we found it was cost savings in the CDC model, and it was improved health and increased cost in the Merck and Pfizer models. At 65 years of age, we found it was cost saving in the CDC model, in improved health and increased costs in Merck and Pfizer models. We went further and evaluated PCV20 and what happened when you added the polysaccharide vaccine. And we found that adding PCV23 yielded better health than PCV20 use alone, but with increased cost, and so was economically less efficient. Next slide, please. And so for these reasons, we have selected the two PCV20 alone for use, since alone yielded better health compared to the current recommendations in the most scenarios. Next slide, please. And so the policy options that are currently under consideration is an age base of PCV15 beginning at 65 years of age in series with the polysaccharide vaccine, and then a risk base for 19 to 64. For PCV20, there are two policy options under consideration. One is an age-based at 50, and then a risk-based for 19 to 49. The second is an age-based at 65 with a risk-base of 19 to 64. And to remind everybody, each of these options is going to be considered in comparison to the current recommendation. Next slide, please. And the target populations for the age-based recommendation, once again, will be presented first because that determines the target populations for the risk-based recommendation. Next slide. And so I want to thank you, and Dr. Andrew Leidner will be presenting a summary of the economic models assessing pneumococcal vaccines in the United States. After that, Dr. Milako Kobayashi will present the evidence to recommendation summary of risk-based PCV15 and PCV20 use in U.S. adults. And following that, we'll discuss considerations for use of both PCV15 and PCV20 in adults and next steps. Thank you.
Thank you, Dr. Peeling, for that very data-rich introduction. And a reminder of where we are today. We'll turn it over to Dr. Leitner to provide a summary of the economic models assessing pneumococcal vaccines.
Good morning/afternoon. My name is Andrew Leitner. I'll be presenting today about 3 economic models that assess the use of pneumococcal vaccines in the U.S. First, I'd like to acknowledge the hard work and countless hours of effort from the 3 modeling teams whose work I'll be summarizing today. I have no conflicts of interest to declare. I'll be using a few acronyms today. Many of these you may be familiar with, but I'll point out a few that may be less familiar as examples. CR will represent current recommendations. PCV13 VEST3 is a long and complicated one that will represent the vaccine effectiveness for the PCV13 vaccine with respect to serotype 3 disease. QALY, which you'll see several times in this presentation, stands for Quality Adjusted Life Year. I'll start by providing some background on cost-effectiveness analysis. Then I'll discuss some recent updates to the CDC model, which was presented to ACIP in June by Dr. Charles Stecker. Then I will provide an overview of the 3 available models. Then I'll describe the model results, which will be structured by first talking about age-based analyses, then risk-based analyses, then analyses that have combined estimates for age and risk-based vaccinations. At the end, there will be a brief summary and discussion. But next, we'll start with the cost-effectiveness analysis or cost-effectiveness background section. The objective of a cost-effectiveness model is to estimate a cost-effectiveness ratio, which compares the cost and outcomes of 2 vaccination strategies. This ratio captures the change in cost divided by the change in outcomes when a new intervention is compared to an alternative. In the example in the green box, the new intervention is identified with the subscript high valency PCV at age 65, and the alternative is indicated with CR for current recommendations. The difference in cost between the two strategies divided by the difference in outcomes produces a cost per health outcome gained, which is an estimate of the economic value of the new intervention, in this case, high valency PCV at age 65. A variety of outcomes can be considered in cost effectiveness analyses, but in this presentation, the primary outcome will be QALYs. Before I present any cost effectiveness ratios, I thought it could be helpful to get oriented to how to interpret some of these results that we are going to see. The cost effectiveness ratio equations in the top right, just for your reference, the table on the left shows how to interpret different values of the ratio when the change in cost is positive or negative. That's indicated in the first column or the row headers, and when the change in outcomes is positive or negative, which is indicated in the column headings. If change in costs and the change in outcomes are both positive or greater than 0, then the cost effectiveness ratio will be characterized by the top right cell in this table. These kinds of ratios are presented as numeric values or as cost per health outcome gained, as was discussed on the previous slide. If the change in cost is negative and the change in health outcomes is positive, then the cost effectiveness ratio will be characterized by the bottom right cell and would simply be labeled as cost saving in results presentations. You saw this kind of result presented earlier during the herpes zoster session. When you see cost saving written in this presentation, it means two criteria are met, costs are lower, and health is improved relative to the comparison or the current recommendations. Moving clockwise from the bottom right to the bottom left cell, if a cost effectiveness ratio is associated with negative costs and negative health outcomes, then that cost effectiveness ratio is labeled lower costs and lower health outcomes. The numeric value of the cost effectiveness ratio, the dollars per QALY, will be presented in parentheses, but this numeric value will have a different interpretation than a numeric value from the cost effectiveness ratios in the top right cell. Another term just to be familiar with is health improving. If the change in health outcomes is positive, then the cost effectiveness ratio is somewhere on the right side of this table where the change in health is greater than 0. These results can be characterized as health improving. Another way to consider these characterizations is with a graph like the one on the right. This graph is called a cost effectiveness plane or a CE plane. This is just a more visual version of a table on the left. Higher health is represented by moving to the right in the graph, lower health is to the left. Higher costs are represented by moving up on the graph, and lower costs are moving down. Sometimes I might refer to these areas on the graph as quadrants, such as the cost-saving quadrant or the lower cost and lower health quadrant. Later in this presentation, there'll be several scenarios from the CDC model. In some of these cases, the scenario results will all be found in the same quadrant. For example, they may all be cost-saving. This would be a consistent finding or a stable result for a given strategy. However, in other cases, the scenario results may not be as stable, and across a handful of scenarios, there could be cost-saving result, a result with higher cost and higher health in the top right quadrant, and one that's in the bottom left quadrant with lower cost and lower health. Since both stable and less stable scenario results will show up later in this presentation, I wanted to provide this slide to hopefully provide some orientation for those results when we see them later. The policy questions being considered for the new pneumococcal vaccines are fairly complicated. There's age and risk components to the considerations, and for one of the vaccines, there's currently 2 different options for age-based considerations. With this in mind, the results we'll see today are going to be organized to first discuss the assessment of the age-based analyses, then there will be a discussion of the risk-based analyses, and finally there will be a discussion of analyses that combine age and risk-based vaccinations into one policy package. So basically I'll show you a set of cost-effectiveness ratios for age-based, for risk-based, and for that combo group where age and risk are combined. Now we'll move on to describing some of the more recent updates to the CDC model. Following the June presentation, based on further review of evidence and further discussions with the work group, several inputs have been revised. These revisions were applied to the base case model settings, and they included reduced duration of waning protection for PCV, increased initial VE for PPSV23 against IPD among healthy and CMC populations, and reduced initial VE assumptions for all vaccines among immunocompromised populations. These changes are indicated with red and bolded text in the table. The red changes are more meaningful for the model results. Based on these changes, we would expect strategies that use PPSV23 to become slightly more favorable following the updates to the CDC model, and I'll show those updated results on the next slide. This slide presents results from a combined analysis, so combining age and risk-based vaccinations, from two versions of the CDC model. The first column of results used inputs from the June presentation, and the last column uses updated inputs that were on the previous slide. Note that the combined age and risk-based assessment for PCV20 strategies did not qualitatively change. These results remained in the cost-saving quadrant of the cost-effectiveness plane, included for your reference on the bottom right-hand side of the slide. Note that the assessment of PCV15 with PPSV23 in series did become more favorable because the value of the cost-effectiveness ratio declined, as would be expected given the updated input values. For the PCV15 PPSV23 strategies, the cost per quality gained declined by about $50,000 in the updated version. And both the June version and the updated version would be found in the upper right quadrant of the CE plane, indicating this strategy has higher costs and higher qualities relative to current recommendations. Now we'll move on to an overview of the available models. With 3 models and such a complicated policy deliberation, there'd be no way to present all the inputs and completely describe all of the models in one presentation, but this table presents a few selected model characteristics that capture some of the most important attributes and differences between the models and will also inform our discussion of results. In this table, we have model characteristics down the left side and 3 models listed across the column headers. A few things to note. Looking at the second row, results from the CDC and Pfizer models were organized around one base case, but results from the Merck model were reported as from 4 different scenarios. Each scenario had a different set of assumptions for vaccine effectiveness. So for this reason, in this presentation, the Merck model results will always appear as a range that represents their 4 VE scenarios. The last row of this table describes how the models accommodate transitions from lower risk status to higher risk status. An example of a risk status transition would be a model that starts with an individual who is healthy and allows that individual to transition or to be diagnosed with a CMC condition at a later point in the model. The CDC and Pfizer model includes these kinds of transitions, and the Merck model does not. Generally speaking, allowing for the model population to develop higher risk conditions would increase the projected burden of disease and would lead to a lower cost-effectiveness ratio. Since the Merck model did not include these kinds of risk state transitions, we might expect the Merck model to produce higher estimates than the other 2 models. We have a few additional model characteristics on this slide, and I'll go over a couple of them. In the second and third rows, a couple inputs related to vaccine effectiveness, PCV-VE serotype 3, lower than other serotypes, and PPSV23 VE against pneumonia, greater than 0%. For these characteristics, the Pfizer model base case used assumptions where PCV was equally effective against serotype 3 as it was against other serotypes, and assumed no VE for PPSV against pneumonia. In general, these 2 assumptions would make the Pfizer base case more favorable to PCV-focused strategies relative to the other 2 models. Looking at the next to last row, the CDC model used a different comparator for the risk-based analysis than the other 2 models. The CDC model compares risk-based use of a new vaccine with age-based use of that same new vaccine. In contrast, the Merck and Pfizer models compare risk-based use of the new vaccine with risk-based use of the currently recommended vaccines. Both approaches provide useful information about the value of risk-based vaccinations, but this difference in approach between the CDC model and the other two will limit the extent to which we can compare the results across all three models in the risk-based analysis. All three models included sensitivity analysis. From the sensitivity analysis, important inputs were identified, and those inputs included vaccine effectiveness, both initial VE and waning protection, indirect effects from a possible pediatric program using the new vaccines, and the incidence of pneumonia. Moving on to the results, first up is the age-based results. The age-based results discussion will start with PCV20 at age 65 and at age 50. Looking at the top row, when the age of vaccination was set to 65 years old, the models are fairly consistent. CDC and Pfizer were cost-saving in their base case. The four scenarios from Merck yielded a range that included cost savings and went up to $39,000 per quality gained. Looking at the bottom row, when the age of vaccination was set to 50 years old, the results across the models are less consistent. Of note, the CDC model found lower costs and lower qualities in the base case. This is a result characterized by that lower left quadrant of the CE plane, again on the right side of the slide for your reference. While this estimate projects lower health than the current recommendations, the estimated economic value could be considered okay because the numeric value in the parentheses indicates that for every one quality is lost, $5.3 million could be saved. On the next slide, we'll look at some scenarios from the CDC model that will help put this result into more context. Still in the bottom row of the table, but now looking at the Pfizer model result for vaccinations at age 50, the estimated cost was $18,000 per quality gained. This is a health improving result. The Merck model estimated a cost per quality gained that ranges from $174,000 to $514,000 per quality gained. And again, that result was health improving. As was mentioned in the model overview section, the Merck model did not include transitions to higher risk levels and assumed more favorable VE assumptions for PPSV in some of their scenarios. We believe these assumptions contribute to the differences in results for that strategy. This slide shows additional results from the CDC model across several scenario analyses that were conducted. The name of the scenario is in the column heading, and in the far right of the table there are two columns with bold text, one that summarizes the number of scenarios with health improvements and one that summarizes the number of scenarios with cost savings. There are three main takeaways from this slide. The first is that across the scenarios for PCV20 vaccination at age 65, all scenarios indicate cost savings. This is a very consistent and stable result for this strategy. The second takeaway is that the results assessing age 50 vaccinations are less consistent across scenarios. However, 3 of 5 are health improving and 2 of 5 are cost saving. The last takeaway is that when comparing the strategies at age 65 and at age 50, the strategy at age 65 would be preferred from a strictly economic perspective based on the results from this model. At age 65, there are more scenarios with improved health and cost-saving results. That said, some scenarios at 50 years old indicate health may not be improved, but this finding is not stable, and under a few different assumptions, this strategy may be health improving and may be cost saving. Staying with the age-based analyses, but switching gears from PCV20 to PCV15 and PPSV23 in series. In the CDC model, this vaccine series at age 65 yielded cost savings. And in the Merck model, it yields a cost per quality in the mid $200,000 range. As discussed previously, these differences appear to be related to differences in how the two models incorporate risk transitions, vaccine coverage assumptions, and vaccine effectiveness assumptions. I will also add that Merck did provide a sensitivity analysis which tried to use similar vaccine coverage assumptions as the CDC model, and this sensitivity analysis estimated cost savings. This result is indicated by SA cost saving in the Merck model result cell. Taking a closer look at some scenarios from the CDC model, notice that the results are quite consistent for the use of the series at age 65, with 4 of 4 scenarios improving health and yielding cost savings. Now I'll move on to the assessments of risk-based vaccinations. As part of this subsection, when possible, I'll talk about the models that produced an assessment of the combined strategies. Looking at risk-based use of PCV20, the top row focuses on adults 19 to 64. The bottom row focuses on adults 19 to 49 years old. As mentioned in the model overview section, the CDC model conducts a different kind of analysis than the Merck and Pfizer models. The CDC model conducted an incremental analysis that compares the use of PCV20 at younger ages to the use of PCV20 at age of 65 in the top row and 50 in the bottom row. By contrast, the Merck and Pfizer models assess the use of PCV20 in a risk-based setting relative to current risk-based recommendations. Because of the different analytical approaches, the CDC result is not directly comparable to the Merck and Pfizer results. However, note that all of these results indicate health is improved with higher costs. And so we're in the top right of that CE plane. A quick side note on the Pfizer model, these results include potential pediatric indirect effects. When indirect effects are removed, the 19 to 49 risk-based estimate on the bottom row was cost saving. I did not have the results for the 19 to 64 risk-based only analysis without indirect effects. So that's why this table shows with indirect effects. The last point I'll make on this slide is that when the results are compared within each model, the cost-effectiveness ratios in 19 to 49-year-old strategies were generally higher than the 19 to 64-year-old strategy, and this is true for all 3 models. For example, the $483,000 per quality is greater than $292,000 per quality in the CDC model. On this slide, instead of looking at just risk-based strategies in isolation, the risk and age-based strategies are put together in the same analysis and assessed as a combined policy strategy. When the age threshold is set to 65, the combined assessment was found to be cost-saving in both the CDC and Pfizer model. When the age-based vaccinations occur at age 50, the CDC model remained cost-saving, and the Pfizer model has a cost of $11,000 per quality gained. Also note, for these Pfizer results, we've gone back to not including the potential pediatric indirect effects, which is consistent with the CDC base case model assumption. Switching gears from PCV20 to PCV15 and PCV23 in series, this slide shows the age-based result, which you saw a few slides ago in the section focused on age-based results. The risk-based analysis is included here in the middle row, and the combined age and risk-based analysis for the CDC model is included in the bottom row. Note that in all the models, the risk-based strategy improves health and has higher costs. Same caution as before with regard to comparing results across models due to the difference in approaches. The final cost-effectiveness ratio for the combined strategy in the CDC model was $338,000 per quality gained. Okay, final section of the presentation is coming up with a quick discussion and then a brief summary of all the results we've seen. There's one other model in the research literature that was published this summer in AJPM. This model looked at age-based recommendations at age 65 only. In addition, this model focused on assessing the value of vaccinations for healthy and CMC populations, so no immunocompromised populations, and there was no risk-based analysis in this study. So the focus of this study was much more limited in scope than the three models we've discussed today so far. In addition, this model included several assumptions that make the results less favorable than the models summarized earlier. However, I did want to include this model because it is on topic, it is published in a peer-reviewed journal, and I think it provides helpful context. Due to the focus of this study and the assumptions, the results included at the bottom of this slide could be thought of as a sort of upper bound on the likely value of these age-based vaccinations. It's therefore reassuring that these results are indeed higher cost-effectiveness ratios than were found in the other models we looked at today. Today I've shown you a range of cost-effectiveness estimates. Values across models were fairly consistent in one analysis of PCV20 use at age 65, but were less consistent in other analyses. This is due to differences across the models, structural choices, as well as input uncertainty. A couple of the important inputs that were explored in sensitivity analyses included vaccine effectiveness, both initial VE and waning protection, indirect effects from possible pediatric vaccination program. Adverse events were not included in the three main models reviewed today, but they were included in the Pittsburgh model. Comparisons across models are made even more challenging for this policy consideration than what might be more typical for models presented to ACIP, just because of the number of policy options that were initially considered and the number of different vaccines that were involved. Anytime a single modeling framework is being used to address such a heterogeneous policy context, generally speaking, it's going to make cross-model comparisons very challenging. I have just 3 more slides where I will try to quickly summarize all the results we've seen today, starting with age-based use of PCV20. PCV20 at age 65 was health improving across all age-based results, and most estimates were cost saving. There were 3 scenarios in the Merck model that were not cost saving, and in those scenarios, vaccination was estimated to cost $39,000 per quality or less. PCV20 at age 50 was health improving in many results, but not all. Pfizer and Merck base case indicated health improvements in their main analyses. The CDC model indicated health improvements in 3 of 5 scenarios. The Pfizer model and Merck model did not indicate cost savings, but estimated a cost of $18,000 per quality for Pfizer and a range from $173 to $513 per quality in the Merck model. The CDC model indicated cost savings in 2 of 5 scenarios. Next to last slide, summary of risk-based and combined analyses for PCV20. Improved health was indicated in all risk-based strategies and models. For risk-based use of PCV20 ages 19 to 64, assessments indicate a broad range of possible value from $11,000 per quality to $292,000 per quality gained. However, when risk-based vaccinations were combined with age-based vaccinations, assessments indicated cost savings in 2 of 2 models. Risk-based use of PCV20 among 19 to 49-year-olds, again, assessments indicate a broad range of value. Combined age and risk-based assessments indicate more favorable value, where the CDC model indicates cost savings and the Pfizer model indicates costs of $11,000 per quality gained in the combined analysis. Switching gears from PCV20 once again to PCV15 and PPSV23. In the age-based analyses, improved health was indicated in all main results, with cost savings indicated by the CDC model in 4 of 4 scenarios. In the risk-based analysis, improved health and higher cost was indicated in all main results. Risk-based only strategies yielded a broad range of possible values from $250,000 to $656,000 per quality gained. The combined age and risk-based assessments indicated values that were more favorable than looking at risk-based alone. The CDC model had $338,000 per quality gained in their combined analysis. Okay, just to recap everything we've looked at today, we did talk about a background. We described the updated results to the CDC model, and then we talked about all the results from the available models. And I would just like to conclude once again and thank all the modeling teams that contributed to this presentation. I'd also like to thank my colleagues around CDC who contributed to the economic reviews and to the discussions of these models leading up to this presentation.
Thank you, Dr. Leitner, for your very thorough presentation. This presentation is now open for questions. As individuals may be thinking about their questions, I have two clarifying questions, Dr. Leitner. One is on slide 14, if you're able to go there, or you might just know what I'm talking about, which is for the CDC comparator group, you actually highlighted the difference here. Could you explain that one more time, what your comparator group was?
Sure. So the comparator group was, for example, if you're looking at PCV20 risk-based use, 19 to 64, the comparator group for that intervention would be age-based use of PCV20 at age 65. So this model installs the age-based policy and then adds to that in an assessment the risk-based at younger ages.
Okay, thank you for that clarification. And then there was another slide that I'm not going to be able to tell you the number on, but you had mentioned that in one of your slides, the Pfizer model did include indirect effects in one of the outputs you were looking at in the table in comparison to other slides. And I think that's where the 11,000 or so came from. Mm-hmm. But I wanted to just clarify for that slide. I'm not sure when you compare all the, okay, so I guess my question is, when you were speaking about indirect effects, are you speaking about indirect effects from adults being vaccinated, or are you speaking about indirect effects from a childhood vaccination program?
The indirect effects that were modeled were from a hypothetical childhood program using the new vaccines.
Oh, okay. And so those results were not disaggregated to exclude that since there is no PCV20 childhood program, correct?
Right. That's why we focused everything on the no indirect effect version where we could.
Thank you. I see Dr. Zimmerman has raised his hand.
Thank you. Very nice presentation. One area that of the PCV20 at age 50 that I think might need a little more comment, and that is just to reemphasize that it had a waning of 15 years. And so it's possible to conceive of a dose at 50, and then hypothetically, one could give a dose at 65. And so it's not necessarily an either or. You have to do it at 50 or at 65, but that the work group could consider if a booster is needed, if there was a 50 age policy, that if a booster was needed at 65, could then look at that in a separate analysis at a separate time. And I think you can see the potential benefit in your scenario where the duration of immunity went out to 20 years in that additional scenario. So I just wanted to, because in 15 years from now, we may have lots of new pneumococcal vaccines, even potentially different basis for how they're made. And so we may have options. And so I didn't want it to, I guess, look at, we had to do a 50 or 65 as a dichotomous, never again could you get something, but instead this could be 50 as the beginning, and then a 50, once we get 15 years down the road, we could look at what would be the follow-up vaccine needed then. Thank you.
Thank you. Are there any additional questions? Oh, Dr. Paling.
All right, thank you. And I very much appreciate Dr. Zimmerman's point, and that is true. It's important to clarify that for the work group, we did not consider any revaccinations in any of the studies that we did. I just wanted to make sure that was clear.
Thank you. Dr. Leitner, if you'll indulge me on perhaps one last question that I might have missed, but it seems to me, well, did each of the models have the same estimated cost of a vaccine for PCV15 plus PPSV23 and PCV20? And I ask also because I don't know if the prices are set, but the other question that seems obvious to me is whether or not to compete on price in this instance. As long as there's improvements in health, the cost effectiveness ratios are driven by a variety of factors, but in order to lower the CE ratio, one more straightforward way would be to impact or change the cost estimate. And so how much variability, what were the estimates used, and then how much sort of variability did you look at to understand whether or not sort of one of the models, and I'm looking particularly at the PCV15 plus 23, whether or not that meaningfully changed the CE ratios?
So the first thing is all the models were harmonized on their vaccine cost assumptions. So they all use the same thing. There were some sensitivity analyses on vaccine costs in the Pfizer model, but I do not think there was a cost analysis in the Merck model. I could be incorrect. I can look that up and let you all know. And I don't have the actual cost values off the top of my head either, and I didn't provide a backup slide for that either. So I'll send all that to the committee later today.
Thanks. Or maybe we can come back after, and if you have a chance to let us know, that'd be great.
Sure.
Thank you. Ms. Coyle.
Thank you so much, and I really appreciate the presentation. I have to say, I'm slowly coming to terms with vaccine recommendations becoming more complicated going forward. I think all of the conversations and meetings over the last several months are really pointing in that direction. With that in mind, I'm curious if anybody is really looking at developing an adult age-based platform. I think one of the greatest successes of the childhood platform is that we're able to co-administer vaccines at specific ages. And it seems like as we start to add more of these adult vaccines, we're not necessarily looking broadly across the suite of adult vaccines being offered. And I'm just thinking about, vaccines work best when more people get them and we achieve that herd immunity. And if there's a way to streamline the practical reality of implementing some of these vaccines, I really think it could have an impact on some of these economic impacts and the cost effectiveness of some of these vaccines. So I guess all this to say, it feels like we're at a point where we may need to look even more broadly at, what does it look like creating a platform for adults at specific ages, and then what would the economic impacts of that be? Thank you.
Thank you for those comments. Dr. Paling. Dr. Paling, go ahead.
Oh, my apologies. I just wanted to say thank you for pointing that out. This is really important, and I think there's a huge opportunity because you're right. In the childhood vaccine, we've learned that when multiple vaccines are chosen at the same age group, it does increase. That actually did play into some of the decisions about 50 because that's when the original zoster vaccine is recommended. And so I just wanted to say thank you for this question. It's really important.
Thank you. Dr. Talbot?
It helps when you hit the right button. So I just really wanted to reiterate that point. And one of the things that we have talked about in the work group is really simplifying this overly complicated pneumococcal guidance. And so I think as we address this issue and discuss possible new pneumococcal recommendations, that we really should do it through the lens of how to make this as easy as possible for both patients and providers, and to really look at what are the correct ages to immunize adults, especially older adults. So I think it's really important that we keep bringing that topic back up about ways to improve adult immunization, ways to streamline it, and ways to make it much less complicated. And I'll put a little plug in. It is always better to begin immunizations prior to full onset of immune senescence. And so that's just something to keep in mind when we start looking at what are the right ages to do this. Thanks.
Thank you. Dr. Alt.
I'm the new chair of the schedule work group, and we'll be discussing the adult schedule hopefully at the October meeting. So everybody should save these thoughts for that future meeting. Of course, we'll be discussing changes for 2022, but it sounds like this will go on into the future as well.
Thank you, Dr. Alt. Are there any additional questions for this presentation? Seeing no hands raised, I think we can move on to Dr. Kobayashi's presentation. Are you able to pull that up? And happy to take additional questions at the end of her presentation about the entire session. Thank you.
Thank you very much. I hope you can hear me. So good afternoon or good morning. On behalf of the work group, I will present the data and work group's interpretation on the risk-based use of 15 and 20-valent pneumococcal conjugate vaccines in adults using the evidence to recommendation framework. Before we proceed with the presentation on the risk-based recommendation, I'd like to provide a summary on the work group's interpretation of the ETR domains for the age-based recommendation, which were updated since June after additional cost-effectiveness analysis results became available, as you just saw. The PCV15 option that is currently being considered is should PCV15 be routinely recommended to U.S. adults aged 65 years and older in series with PPSV23. The two PCV20 options being considered are should PCV20 be routinely recommended to U.S. adults aged 50 years and older, and should PCV20 be routinely recommended to U.S. adults aged 65 years and older. The comparison groups are different based on the age groups being considered. This shows the current and new age-based policy options being considered for adults aged 65 years and older. This shows the current and new age-based policy options being considered for adults aged 50 years and older. This age group is being considered for PCV20 only. Here's a summary of the updated work group's interpretation on use of PCV15 in series with PPSV23 in adults aged 65 years and older. The work group believed the new intervention will prevent more disease against the two additional serotypes that are not included in PCV13. There may be improved protection against serotype 3 disease, the most common PCV13 type disease. However, we only have immunogenicity data, and uncertainties on clinical impact remain. Routine use of PCV15 in series with PPSV23 will be a simplified recommendation compared with current PCV13 use based on shared clinical decision-making. In the updated CDC model, the intervention was cost-saving, meaning it yielded better health outcomes and lower costs compared with the current recommendations. On the other hand, some workgroup members believed routine use of PCV15 and PPSV23 series is more likely to disadvantage those with limited access to vaccines and may be less acceptable and feasible for some providers. The workgroup determined that the balance between desirable and undesirable consequences is closely balanced or uncertain. Here's a summary of the updated workgroup's interpretation on use of PCV20 in adults aged 65 years and older. The workgroup believed the new intervention will prevent more disease against the 7 additional serotypes that are not included in PCV13. This will be a simplified pneumococcal vaccine recommendation, which is likely to be more acceptable to stakeholders and feasible to implement. The workgroup believed that this may increase vaccine coverage compared with the current recommendations. This intervention was health-saving across all cost-effectiveness analysis models reviewed and was cost-saving in most. On the other hand, the clinical significance of the lower immunogenicity observed compared with PCV13 is unknown. The non-inferiority criteria was met in phase 3 trials, and we'll look at these data again later. The impact of losing coverage against 4 PPSV23 serotypes is also unknown. The workgroup determined that desirable consequences clearly outweigh undesirable consequences in most settings. Lastly, here's a summary of the updated workgroup's interpretation on use of PCV20 in adults aged 50 years and older, focusing on differences from the previous slide for adults 65 years and older. The workgroup believed that lowering the age-based recommendation may improve vaccine coverage in adults aged 50 to 64 years with underlying conditions, which are more prevalent in certain populations. In general, risk-based vaccine recommendations have resulted in lower vaccine coverage. Therefore, this intervention may be more equitable. The intervention will provide more opportunity to vaccinate adults before they develop conditions that increase their risk of disease. The intervention was health improving in many cost-effectiveness analyses and cost saving in some. On the other hand, as mentioned earlier, due to waning of immunity, the vaccine may not provide sufficient protection later in life when risk of pneumococcal disease increases. In some CDC scenarios, the intervention resulted in worse health outcomes. Since this is a new age group, some workgroup members believe that this intervention could have initial implementation challenges. The workgroup determined that desirable consequences probably outweigh undesirable consequences in most settings. For the risk-based recommendations, the target population is those who did not meet the age criteria for the age-based recommendation, but are currently recommended to receive pneumococcal vaccines due to their underlying conditions, as shown here. In this presentation, I will refer to adults who are currently recommended to receive PPSV23 only as those with chronic medical conditions, or CMC, and those who are recommended to receive both PCV13 and PPSV23 as those with immunocompromising conditions, or IC. According to the National Health Interview Survey, approximately 90% of adults aged 19 to 64 years who are eligible for the current risk-based pneumococcal vaccine recommendation have chronic medical conditions. The Pico question for PCV15 use is, should PCV15 in series with PPSV23 be recommended for U.S. adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions? The population is U.S. adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions. The intervention is one dose of PCV15 followed by PPSV23. The comparison is PPSV23 only for adults with chronic medical conditions, or PCV13 use in series with PPSV23 in adults with immunocompromising conditions. Outcomes considered as critical by the workgroup are vaccine type invasive pneumococcal disease, vaccine type non-bacteremic pneumococcal pneumonia, deaths, and serious adverse events. The two Pico questions for PCV20 use are, should PCV20 be routinely recommended to U.S. adults 19 to 49 years old with chronic medical conditions or immunocompromising conditions? And should PCV20 be routinely recommended to U.S. adults 19 to 64 years old with chronic medical conditions or immunocompromising conditions? The intervention is one dose of PCV20. The comparison and the outcomes are the same as those for PCV15. As a reminder, the ETR framework consists of the following 7 domains: public health problem, benefits and harms, values, acceptability, feasibility, resource use, and equity. Available evidence is usually assessed for each policy question. However, given the overlap in available evidence for the 3 questions being considered, we reviewed the 3 questions in parallel for each ETR domain. The first question is public health problem. Is pneumococcal disease of public health importance in adults aged 19 to 64 years old with chronic medical conditions or immunocompromising conditions? Pneumococcal disease can be divided into invasive pneumococcal disease, or IPD, and non-invasive disease. IPD is less frequent, but a severe form of illness such as meningitis or bacteremia. Non-invasive disease is a more frequent form of illness such as non-bacteremic pneumonia. The 2 figures show the PCV13 type IPD incidence trends in adults aged 19 to 64 years with chronic medical conditions to the left and immunocompromising conditions to the right. After PCV13 was introduced in children in 2010, PCV13 type IPD incidence declined both in adults with chronic medical conditions and immunocompromising conditions. Risk-based use of PCV13 in series with PPSV23 was recommended for adults with immunocompromising conditions in 2012. However, PCV13 IPD incidence in adults with immunocompromising conditions remained stable. This trend is similar to what was observed after routine use of PCV13 in series with PPSV23 was recommended for adults aged 65 years and older in 2014. Based on these findings, ACIP voted to change the PCV13 recommendation in 2019. In 2017 to 2018, approximately 50% of the remaining PCV13 type IPD in adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions was due to serotype 3. Despite the decline in PCV13 type incidence, in 2017 to 2018, adults with chronic medical conditions or immunocompromising conditions had 4 to 9 times higher risk of all IPD and 4 to 7 times higher risk of PCV13 type IPD, shown in orange below, compared with adults without these conditions. The 2 additional serotypes included in PCV15 but not in PCV13, shown in yellow, comprise 11 to 13% of remaining IPD burden in adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions. The 7 additional serotypes included in PCV20 but not in PCV13, shown in yellow, comprised 27% of remaining IPD burden. According to a retrospective analysis of 2 U.S. healthcare claims repositories, adults aged 18 to 64 years with chronic medical conditions had 4 to 5 times higher rates of pneumococcal pneumonia hospitalizations. And adults with immunocompromising conditions had 11 to 18 times higher rates compared with adults with these conditions. The work group determined that pneumococcal disease is of public health importance in adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions. The next domain is benefits and harms. This domain covers several questions. How substantial are the desirable anticipated effects for vaccine type IPD, vaccine type non-bacteremic pneumococcal pneumonia, and deaths from vaccine type disease? How substantial is the undesirable anticipated effect for serious adverse events? Do the desirable effects outweigh the undesirable effects? Although grade of evidence was performed for PCV15 and PCV20 studies, we used a broad search strategy to identify relevant evidence on PCV13 and PPSV23 for background, as we did for grade for age-based policy options presented in June. We leveraged prior literature review from the age-based review for 2019 to 2021, which yielded 923 citations. We performed additional search to identify literature published during January 2012 to March 2019, restricting to those with immunocompromising or chronic medical conditions, which yielded 471 citations. We also contacted manufacturers for unpublished data. After screening and full text review, we identified 5 phase 2 and 3 studies on PCV15 and PCV20. All were immunogenicity studies and did not assess vaccine effectiveness against the critical outcomes. First, we will review evidence on PCV15. 2 phase 3 randomized controlled trials compared the immunogenicity of PCV15 with PCV13, both given in series with PPSV23. V114017 enrolled adults aged 18 to 49 years who are Native Americans in good health and non-Native Americans who have chronic medical conditions. PCV and PPSV23 were given 6 months apart. V114018 targeted adults 18 years and older with HIV. PCV and PPSV23 were given 8 weeks apart. Overall, those who received PCV15 in series with PPSV23 had higher geometric mean titers and percent seroresponders compared with those who received PCV13 in series with PPSV23 in most serotypes shared with PCV13. The differences were significant for one serotype in one study. The certainty of evidence was moderate, as there are no established correlates of protection, and the impact of these findings against the critical outcomes are unknown. As presented in previous ACIP meetings, PCV15 has shown improved immunogenicity against serotype 3 compared with PCV13 when measured 30 days after PCV15 administration. However, the improved response against serotype 3 was less noticeable when measured after PPSV23 receipt. Here are opsonophagocytic activity geometric mean titers, or GMTs, 30 days after PCV on the top and 30 days after PPSV23 on the bottom. Also, the GMTs were generally lower for serotype 3 compared with other serotypes. Similar findings were observed in V114018. The work group determined that the desirable anticipated effects of PCV15 use in series with PPSV23 is moderate. Some work group members believed that the incremental benefit of this intervention may be large in those with chronic medical conditions who are currently recommended to receive PPSV23 only, assuming improved vaccine effectiveness in PCV15 compared with PPSV23. Added benefit may be greater if PCV15 provides improved protection against serotype 3 disease based on immunogenicity data, though clinical benefits remain unknown. On the other hand, PCV13 type disease declined from pediatric indirect effects, and learning from the experiences from routine PCV13 use in series with PPSV23 in adults aged 65 years and older, some thought that the added benefit may be small. PCV15 provides protection against 2 additional serotypes compared with PCV13, which comprise 11 to 13% of remaining IPD burden. For harms, neither study reported any serious adverse events that were associated with the vaccines. The certainty of evidence was moderate because the sample size might have been small to observe any vaccine-associated events. Therefore, the undesirable anticipated effects of using PCV15 in series with PPSV23 was determined to be minimal. Balancing the desirable and undesirable effects, the work group determined that using PCV15 in series with PPSV23 was favorable compared with the current recommendations. For PCV20, we will review evidence for the 2 questions together since the same studies were reviewed for grade. 2 phase 3 and 1 phase 2 randomized controlled trials were identified. All 3 studies excluded adults with immunocompromising conditions, and none specifically targeted adults with underlying conditions. In the 2 studies that used PCV13 in series with PPSV23, the 2 vaccines were given 1 month apart. The first comparison is PCV20 compared with PCV13 for the 13 shared serotypes shown in yellow below. Across all included studies, PCV20 recipients had lower responses by GMT and percent seroresponders in most shared serotypes. However, PCV20 met non-inferiority criteria for 13 shared serotypes by GMT ratio. In one phase 2 trial, data on PCV20 response to the 13 shared serotypes compared with the response after receipt of both PCV13 and PPSV23 as opposed to PCV13 only were available. PCV20 recipients had lower responses in all 13 serotypes by GMT and percent seroresponders compared with those who received both PCV13 and PPSV23. Of note, the interval between PCV13 and PPSV23 that was used in this study was different from what is currently recommended. The next comparison is PCV20 compared with PPSV23 for the 7 shared serotypes shown in blue below. Across all studies, PCV20 recipients had higher GMT and percent seroresponders in all serotypes except for serotype 8. In a phase 3 trial, PCV20 met non-inferiority criteria for 6 of 7 shared serotypes based on GMT ratio. Non-inferiority was not met for serotype 8. The last comparison is the immunogenicity of PCV20 in adults who were 18 to 49 years old compared with adults 60 to 64 years old. In one phase 3 trial, GMTs and percent seroresponders in adults 18 to 49 years were higher for most of the 20 serotypes, and non-inferiority criteria was met for all 20 serotypes by GMT ratio in a phase 3 trial. The certainty of evidence was low, since correlates of protection are not established, so the impact of these findings against the critical outcomes are unknown. Also, the studies targeted generally healthy adults and did not include immunocompromised persons, so they are not representative of the population considered for the policy options. The workgroup determined that the benefits of PCV20 use in adults aged 19 to 49 years or 19 to 64 years with chronic medical conditions or immunocompromising conditions are large. PCV20 contains 7 additional serotypes compared with PCV13, which comprised 27% of the remaining IPD, and some members thought that a simplified recommendation may improve vaccine coverage. Some workgroup members expressed concerns about the lower immunogenicity observed compared with PCV13. However, PCV20 response met non-inferiority criteria in phase 3 trials, so the clinical significance is unknown. Also, PCV13 type disease declined from pediatric indirect effects, as we saw earlier, so the impact on remaining PCV13 type disease may be small. Some expressed concerns about fewer serotypes covered by PCV20 compared with PPSV23. However, the cost-effectiveness analyses showed improved health outcomes compared with the current recommendations. There were no vaccine-related serious adverse events reported in the included studies. The certainty of evidence was moderate because the sample size might have been small to observe any vaccine-associated serious adverse events. The undesirable anticipated effects from use of PCV20 was determined to be minimal. In balancing the desirable and undesirable effects, the workgroup determined that both PCV20 interventions were favorable compared with the current recommendations. Next is values and preferences. The first question is, does the target population feel that the desirable effects are large relative to undesirable effects? And the second question is there important uncertainty about or variability in how much people value the main outcomes? We performed a PubMed search on U.S. studies published in the past 5 years in adults who qualify for the current risk-based pneumococcal vaccine recommendations. We identified one online cross-sectional survey study that assessed vaccine-related beliefs, reasons for hesitancy, external influences on vaccination, and prior vaccination. Residents in Tennessee aged 19 to 64 years with risk-based indications were enrolled. The study population was mostly female, white, non-Hispanic, and had at least some college education. Most common qualifying conditions were current smoker, asthma, and diabetes. 19% indicated that pneumococcal vaccine was offered to them in the past 5 years. More than 90% indicated that vaccines can prevent serious disease, but 1/3 were reluctant, hesitant, or resistant to a recommended vaccine. The common reasons were not knowing it was needed, fear of needles, or concerns about safety. The odds of vaccine hesitancy or resistance were greater in minorities, those believing others like them do not need to get vaccinated, those recalling negative media about vaccines. For PCV15 use in series with PPSV23, the workgroup agreed that adults probably feel that the desirable effects from vaccination are large relative to undesirable effects. PCV13 and PPSV23 have been used in series and are considered safe. Some workgroup members believe that acceptance of pneumococcal vaccines is higher than other vaccines. The workgroup determined that most adults with conditions that increase their risk of pneumococcal disease would value individual protection from vaccination. For the second question, the workgroup determined that there are probably important uncertainty or variability. Some workgroup members believed that increase in recommended vaccine doses in adults with chronic medical conditions was an important source of uncertainty or variability. However, the workgroup determined that most adults would probably perceive that the desirable effects outweigh the undesirable effects. For PCV20 use, the workgroup also agreed that adults probably feel that the desirable effects from vaccination are large relative to undesirable effects. For the second question, the workgroup determined that there was probably not important uncertainty or variability. The workgroup acknowledged that there may be some uncertainties in how changing recommendations from PPSV23 only to PCV20 only, or from PCV13 in series with PPSV23 to PCV20 would be perceived. However, the workgroup determined that most adults would probably perceive that desirable effects outweigh the undesirable effects. The next domain is acceptability. Is the option acceptable to key stakeholders? In June, we summarized findings from 3 surveys to assess the acceptability of the age-based options, which are shown here. There were 2 healthcare provider surveys and 1 survey targeting members of the Association of Immunization Managers, or AIM. We also reviewed findings from another healthcare provider survey conducted by Merck last month, targeting physicians, physician assistants, or pharmacists who provide or administer pneumococcal vaccines. Responders preferred a simplified pneumococcal vaccine recommendation, potentially the same recommendation across age and risk groups. There were mixed responses on the use of PCV in series with PPSV23. A single vaccine was preferred over a sequential vaccine regimen in the Merck survey. A routine PCV and PPSV23 use was the most preferred among provided options in the survey by Pfizer. Implementation and communication challenges and health equity concerns were expressed in the AIM survey, since a recommendation with 2 different vaccines requires capturing the correct vaccination history or having adults return to complete the vaccine series. In the Merck survey, respondents were asked to select 2 hypothetical vaccine profiles with different attributes and levels. Immunogenicity and total additional coverage of serotypes associated with remaining pneumococcal disease yielded the highest probability of preference. Is recommending PCV15 in series with PPSV23 acceptable to key stakeholders? The workgroup interpretation was varies. Some members believed that this recommendation may add more burden to providers, since PCV and PPSV23 series will be offered to a larger group of people than the current recommendation. On the other hand, some believed that aligning the recommendations for adults with chronic medical conditions and immunocompromising conditions will be a simplification of recommendations. Also, cost-effectiveness analyses showed that the new intervention will prevent more disease compared with the current recommendation. Is recommending PCV20 acceptable to key stakeholders? The workgroup interpretation was probably yes. The workgroup believed that this will be a simplification of current risk-based recommendations, and the cost-effectiveness analysis showed that the new intervention will prevent more disease compared with the current recommendation. Next is resource use. Is the option a reasonable and efficient allocation of resources? As shown in the previous presentation by Dr. Leidner, cost-effectiveness analyses that assessed the risk-based use of PCV15 in series with PPSV23 improved health and increased costs with a broad range of cost-effectiveness ratios, reflecting the differences in model structure and assumptions. The CDC model assessed the combined impact of the age and risk-based intervention and indicated that the values were more favorable than the risk-based intervention alone. The workgroup opinion was initially split between probably no and probably yes, but eventually determined that the additional health benefits from the new intervention was potentially sufficient to outweigh the additional cost associated with the intervention. Cost-effectiveness analyses that assessed the risk-based use of PCV20 in series with risk-based use of PCV20 showed improved health with a broad range of possible values, but generally favoring risk-based use of PCV20 in adults aged 19 to 64 years old with chronic medical conditions or immunocompromising conditions compared with use in adults aged 19 to 49 years. Models that assessed the combined impact of the age and risk-based interventions indicated more favorable values, and the interventions were cost-saving in some scenarios. The workgroup determined that recommending PCV20 is a reasonable and efficient allocation of resources. Additional health benefits from the new intervention were considered to be sufficient to outweigh the additional costs associated with the intervention. Also, some of the combined age and risk-based assessments were cost-saving. What would the impact on health equity be? As we presented in June, pneumococcal vaccine coverage in adults aged 19 to 64 years with risk-based indications has been low, compared with adults 65 years and older with age-based recommendations. By race and ethnicity, the Hispanic population had significantly lower coverage compared with the white population. One study reported the influence of social determinants of health on vaccine uptake and time to pneumococcal vaccination. The study utilized nationwide convenience samples of commercial insurance claims data from 2013 to 2016. Adults aged 18 to 64 years with no prior pneumococcal vaccination before diagnosis of risk-based indications were included. 25% were vaccinated within 1 year of diagnosis of risk-based indications, and the odds of vaccination were lower among areas of higher poverty, areas with limited internet access, adults not receiving a seasonal influenza vaccine. Time from diagnosis of risk-based indications to vaccination was lower in rural communities and communities with less internet access. The workgroup determined that recommending PCV15 in series with PPSV23 would probably have no impact on equity. Some members thought that alignment of the recommendation for adults with chronic medical conditions and immunocompromising conditions may increase vaccine coverage, prevent more disease, and reduce disparity in vaccine type disease. Others believed that a routine PCV and PPSV23 series recommendation is more likely to disadvantage populations with limited vaccine access. The workgroup determined that PCV20 use would probably increase health equity. A single risk-based vaccine recommendation may increase vaccine uptake and reduce disparity in vaccine type disease. Some believe that introduction of any new effective adult vaccine may decrease equity, at least in the short term, disadvantaging those who have limited vaccine access or lack of awareness of the new recommendation. The last domain is feasibility. Are the options feasible to implement? The work group determined that recommending PCV15 in series with PPSV23 was probably feasible. PCV13 and PPSV23 series is currently recommended for immunocompromised adults. On the other hand, extending the vaccine series recommendation to adults with chronic medical conditions will result in a larger number of people targeted for the vaccine series, which may increase logistical and financial burden. The work group determined that recommending PCV20 for either group is feasible. This is the summary of the work group interpretation for all ETR domains except for public health problem by policy question. Differences were noted in all domains shown here: benefits and harms, values, acceptability, resource use, equity, and feasibility highlighted in blue. Should PCV15 be recommended in series with PPSV23 for persons aged 19 to 64 years with chronic medical conditions or immunocompromising conditions? The work group's interpretation was desirable consequences probably outweigh undesirable consequences in most settings compared to current recommendations. The perceived benefits were from simplification of the current risk-based recommendations and the potential to prevent more vaccine-type disease by recommending PCV15 in series with PPSV23 for adults with chronic medical conditions, given that adults with chronic medical conditions comprise approximately 90% of the target population and are currently recommended to receive PPSV23 only. Some work group members believed that the new recommendation may be less acceptable to providers and potentially the target population and less feasible to implement compared with the current recommendations. Impact on the prevention of serotype 3 disease remains unknown. If there is increased protection against serotype 3 disease, then the benefits from use of PCV15 will be greater. For the two PCV20 options, the work group determined that desirable consequences clearly outweigh undesirable consequences in most settings. Now that I've reviewed the work group's interpretation of the ETR domains for both age-based and risk-based use of PCV15 and PCV20, I'd like to discuss next steps. Here are the current age-based and risk-based Pico questions for PCV15 use. Should PCV15 be routinely recommended to U.S. adults aged 65 years and older in series with PPSV23? Should PCV15 in series with PPSV23 be recommended for U.S. adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions? And I noticed that the first bullet, I thought it didn't have PPSV23. Okay. Here are the current age-based and risk-based Pico questions for PCV20 use. If an age-based recommendation for adults aged 50 years and older is considered, the questions are: should PCV20 be routinely recommended to U.S. adults aged 50 years and older? And should PCV20 be recommended for U.S. adults aged 19 to 49 years with chronic medical conditions or immunocompromising conditions? If an age-based recommendation for adults aged 65 years and older is considered, the questions are: should PCV20 be routinely recommended to U.S. adults aged 65 years and older? And should PCV20 be routinely recommended for U.S. adults aged 19 to 64 years with chronic medical conditions or immunocompromising conditions? At this time, revaccination strategies are not being considered. For example, if PCV15 in series with PPSV23 or PCV20 is recommended for an adult aged 49 years with indication, no additional doses are being considered at age 50 or 65 years. We'd like to ask the following questions to the committee. Does the committee agree with the policy options being proposed for the October meeting? Are there additional data the committee would like to see before deciding on policy options? And this is all the questions in one slide. The next steps considered by the work group is to review available data to evaluate the interval for PCV15 use in series with PPSV23, and review available data to draft guidance on use of PCV15 or PCV20 for adults who already received PCV13 and PPSV23. I'd like to thank many people for their contributions, including workgroup members, CDC colleagues, and others. Thank you very much.
Thank you, Dr. Kobayashi. This presentation is now open for questions and discussion. And just given the limited time we have remaining, I want to just confirm that I understand what the best next questions are. So based on what Dr. Paling said in the beginning, sounds like the questions might be for each of the vaccine candidates compared to current recommendations. Could the committee start by deliberating on age-based recommendations? Is that fair, Dr. Kobayashi?
Yes, thank you. That sounds fair.
Okay. So I would open this up to committee members to comment on the data that we've seen to date, to think about age-based recommendations for the vaccine candidates on the table. Clearly, people are still processing the information. Dr. Long.
I would just like to comment. I'm a working group member, so I could count the number of headaches I've had in the last year, and every one of them came at the end of one of these pneumococcal work group calls, because it's so complicated. It is so very complicated. But one of the things that we thought would be especially appealing, besides the better health care at not terribly much cost on the age-based recommendations, would be to build what others have considered to be very important, which is a potential vaccine platform at 50 years of age, as other vaccines are recommended then. Thanks.
Thank you. And can I ask Dr. Long your thoughts about age-based recommendations and 65 and older for both products, or 65 and 50 for the two products?
For the two products, well, we were, for age-based recommendations for otherwise healthy people, we did not think that 15 plus 23 was an option for 50. And it could be still considered as an option for those 65 and older. We didn't mention today, both Dr. Paling and Dr. Kobayashi did such a fabulous job of so much and so difficult to understand. But what we didn't get a chance to mention yet is we did weigh the untoward immunologic effects of polysaccharide vaccine and the blunted ability to boost those as well. So beyond what we anticipate as the efficacy associated with immunogenicity, we did consider also the probable disadvantage for the general population of potentially everybody receiving polysaccharide as part of their 50-year-old group of vaccines. Dr. Paling and Dr. Kobayashi, if I didn't say that correctly, please jump in.
Yes, thank you, Dr. Long. We did definitely discuss that, possibility as among the work group members. There are still some unknowns about some of the data, but there are data suggesting that there may be some issues with blunting with future vaccination when polysaccharide vaccine is given first before the next vaccine.
Thank you. Dr. Goldman?
Thank you. First, as always, incredible presentation and really applaud all the hard work. I'm on the work group as well, so not so much a question, but a comment from the primary care perspective. And to answer your question regarding the thoughts on age-based recommendation, I am certainly all for it. One of the biggest frustrations and difficulties I had in teaching my colleagues how to vaccinate was based on the conflicting, confusing pneumonia risk-based recommendations. So the simplification based on age, I think, will actually improve vaccine uptake, improve equity, and improve overall health. Plus, I always weigh the individual risk versus the societal risk. And while, as when we discuss PCV13, that the individual may still get benefit, even though the population may not see it because of indirect effects, I think that lowering the age of a pneumococcal recommendation, making it more universal, will help both the individual as well as society, as well as improve uptake and equity for the vaccine. And of course, later we can discuss specifics on the policy recommendations, but I think age-based universal is really the most appropriate way to approach these vaccines. Thank you.
Thank you. I'm going to go to Dr. Bell next. Dr. Bell?
Thank you. Apologies. This is actually just a very blockheaded clarification. I just want to make sure that I understand. So when we're talking about age-based recommendations, what the work group has sort of put before us is potentially age-based for starting at age 50 for PCV20, but age-based starting at age 65 for PCV15. Along with the polysaccharide vaccine. And if I'm correct about that, and then I just heard a little bit of what the work group's thinking was about why it wouldn't be appropriate to offer PCV15 and the polysaccharide vaccine at age 50. But I would be interested in hearing that again, because to me, there's a little bit of you don't get as much benefit from simplification if you have one age-based recommendation for one product and another different age-based recommendation for a second product.
Yes, this is Dr. Kobayashi. Thank you very much for your question. So this was based on reviewing additional cost-effectiveness analysis results, as well as discussion that Dr. Long mentioned earlier about data and what we know from immunogenicity studies. And so for the cost-effectiveness analysis data, giving PCV15 in series with PPSV23 at age 65, so we're focusing more on the age-based recommendation, that was more consistently cost-saving, whereas it was not the case for giving it at age 50. And then, as Dr. Long mentioned, there were some members concerned about the potential immunologic effects by giving, PPSV23 at for younger adults, especially if there is a possibility in the future of considering repeat vaccination or booster doses if new vaccine products become available. So those were kind of the main reasons why the work group decided to focus on PCV15 in series with PPSV23 use at age 65, as opposed to 50 years.
Thank you. And Dr. Paling, you'd like to respond?
Yes, and so Dr. Bell, thank you for that question. And so one of the big points is with PCV20, there were two options that were feasible in our cost effectiveness analysis. And so we wanted to look at both of those, recognizing we're not sure which way the committee will vote. And then once we've determined the age base, then we would look at the risk base. I hope that's answering your question. Thank you.
Thank you. Dr. Glickman.
Sorry to be a second on mute. I had two questions. One is, has the work group considered, and will they make a recommendation about PCV20 in patients previously immunized with the polysaccharide vaccine? And then secondly, I know the data may be limited, but the data you presented today seems to imply that PCV20 was more cost effective than PCV15 plus the polysaccharide vaccine. So why make a recommendation on the latter at all? That will only add to the confusion. And I actually even wonder about the potential for people to get both PCV15 and PCV20 because patients and physicians may not know what vaccines were previously administered.
Thank you for your question, Dr. Gluckman. This is Dr. Kobayashi. So for the first question, yes, the work group is considering guidance for people who have already received PCV13 or PPSV23, so that we hope to provide share some options at the October meeting. And then for the second question, so as Dr. Paley mentioned in her introduction slide presentation, we are considering PCV20 and PCV15 separately. So we are planning to have a recommendation for PCV15 as well as a separate recommendation for PCV15. That's how we're working.
Dr. Paling, I saw your hand go up. Did you want to respond again as well?
Yes, the ACIP needs to make a recommendation on all licensed vaccines, and so we need to go through all this important information. The second thing is both of the vaccines were considered cost savings, and so I do think it's important to consider both vaccines. Thank you.
Thank you. And I see Dr. Long also would like to respond.
Yes, as all of you know, but we have to remind ourselves we can only deal with the vaccines in front of us. We cannot compare to new vaccines. So what are the best recommendations that include or would be uniquely 20, and what are those for the PCV15? And the other thing that I think has not come out, which Dr. Goldman alluded to and others have mentioned, is that the different recommendations for the immunocompromised and the underlying medical conditions was a very big detriment to internists' understanding and patients' understanding, and the time it took for them to understand and then explain with their patients what the different recommendations were. And we felt pretty strongly for that large group of Americans who have underlying medical conditions, it would be a disservice to leave PPSV23 for the problems that it includes.
Thank you, Dr. Long. I'm going to go to Dr. Zimmerman. I'm going to take a brief pause, and I believe our colleagues from Merck and Pfizer would like to make a brief statement, and then I'll go back to Ms. Howell. So Dr. Zimmerman, you're next.
I wanted to point out an advantage in those patients who will develop a complex condition and may develop immune senescence, that vaccination at age 50 may allow them to respond before they develop either a age-based or a medical condition-based condition that interferes with response to vaccine. Those medical conditions might include, for instance, chronic kidney disease. As we know, that prevalence will increase, particularly as people are 50 and above. So I think the age 50 offers us a real opportunity, and I'm glad we can look at a product with that age. Thank you.
Thank you. And actually, I think we are going, I'm just realizing we are a little over time. What I'd like to do is take a brief break, go to public comment. We'll actually come back and allow individuals from Merck and Pfizer to comment. We'll reopen the session for additional questions, and then we'll move on after that to the next session. So right now, let's plan to just take a short break. Let's make it 5 minutes if that's okay with everyone. So it'll be 38 after the hour, and we'll see you back then.